Good afternoon, everyone. It's a pleasure to have you all here. I'm really sorry I was on mute and I kept repeating. My apologies. It's been a wonderful day today, and although it is the last session for today, but it's a very interesting one. And it is an honor to introduce Professor Uma Iyer to the gathering here. Professor Uma Iyer was former head Department of Foods and Nutrition and former Dean, Faculty of Family and Community Sciences. It's over to you, ma'am. Kindly introduce the first speaker.
Good afternoon, everyone. And it's my pleasure to introduce the first speaker of the last session, the convener of this program, Professor Vanisha Nambia. Professor Vanisha did her PhD from the Department of Foods and Nutrition. Along with that, she was then internalized in the department and has done extensive teaching, research and extension activities. She has worked on a wide variety of research projects in the area of public health nutrition as well as clinical nutrition. And she is also working very hard to make Baroda, to see that in Baroda there are many hospitals designated as baby friendly hospital. And today she will be delivering a talk on minimum acceptable diets for pregnant and lactating women for improved food and nutrition security. I welcome Vanisha to deliver your talk.
Ma'am, please unmute yourself. Ma'am, you are still muted.
Can you hear me now?
Yes, ma'am. Yes, ma'am.
Great. Sorry about that. So today I'll be talking about minimum acceptable diets and about minimum dietary diversity for pregnant and lactating women for improved food and nutrition security. Since morning, we have been listening to nutrition equity, needs for internalizing nutrition in various programs and policies, and talking about food systems and empowering our food systems to address the health system so that the overall health and well-being of populations can be transformed. We have also seen the data that we're not doing very well as far as our MIYCN indicators are concerned, and even MIYCN indicators are not doing very well. And this is from the Global Nutrition Report 2020. So I thought, let me take this opportunity to share in this platform, why not have a single tool for the entire country and get some data so that simple policies can be made. The first of it is the minimum acceptable diet for children 6 to 23 months. It is one of the core indicators for assessing the IYCF. And the other 7 indicators we have discussed since morning about early initiation of breastfeeding, exclusive breastfeeding for 6 months, continued breastfeeding for 1 year, introduction of semi-solid, solid or soft foods after 6 months, minimum dietary diversity, minimum meal frequency, and consumption of iron-rich or iron-fortified foods. So this minimum acceptable diets is a composite which consists of 2 parts, the minimum dietary diversity, that is MDD, and the minimal feed frequency. Minimum dietary diversity is calculated, it is basically calculated of the 7 food groups, and used in the indicators are grains, roots, tubers, legumes, and nuts, dairy products, flesh foods, eggs, vitamin A-rich foods, and other fruits and vegetables. Consumption of any amount of food from any of the food group is sufficient to count that there's no minimum quantity, right? So at least 4 out of 7 of these have to be consumed by the child who's from 6 to 23 months of age to consider that as a dietary diversified diet. Now, when we look at the minimum meal frequency, it is the proportion of the breastfed and non-breastfed child between 6 to 23 months of age who receives solid or semi-solid foods or soft foods, but also they have to have on their breast milk, and the categories are different between breastfed and non-breastfed infants. And minimum is defined as when the child is 6 to 8 months, it is 2 times. When the child is 9 to 23 months, it is 3 times breastfeeding, and it is 4 times for non-breastfeeding child who is in the age group of 6 to 23 months. So this indicator is basically a proxy for energy intake from foods other than breast milk. So when you combine both of the above, you get minimum acceptable diets, and that gives you an indicator that is recommended, and that can be further segmented into 6 to 11 months or 12 to 17 months or 18 to 23 months of each. So to sum up, minimum acceptable diet is an indicator. It is a composite indicator. It is composed of dietary diversity and meal frequency, and that is for children. Now we move on to the dietary indicators of a mother. We call it minimum dietary diversity for women, and it has more food groups. So these are the various different types of indicators, and I urge to all the participants to at least, whenever you are doing dietary diet information, whether you're taking 24-hour dietary call or food frequency dietary call, you please convert it into these indicators so that worldwide, when we compile our data or do a meta-analysis, a proper data set is available for all of us to identify what is the MIYCN pattern of that particular area or that particular country. Why is dietary diversity important? Because at the household level, dietary diversity indicators are the proxy for socioeconomic status. At the individual level, these indicators are proxy for diet quality and nutrient adequacy. The DDS scores are so easy to calculate, and after basic trainings, the DDS scores can quantify information, and it tells you about overall dietary intake or the nutrient adequacy. Now, these are indicators and therefore very well established indicators, and for women, we have 10 food groups that have been identified from which the minimum dietary diversity is calculated. So they have to consume 5 out of these 10 indicators, and these are the recommended food groups that of these 5 food groups can be consumed for the women to have a dietary diversified diet. Now, what are these the foods? These are grains, roots, tubers that all come under group 1, pulses under group 2, nuts and oil seeds in group 3, dairy in group 4, meat, fish and poultry as group 5, eggs are separate. Green leafy vegetables and other vegetables are in next group. All the vitamin A rich fruits and vegetables have a separate groups, and then you have other vegetables and other fruits. So basically, the enumerator should record whether the respondent did or did not consume food within each food group. The total number of food groups consumed is summed up. All are equally weighed, and then the population level indicator is calculated based on the following formula. Now, when you are working in a community with around 500, 600 population or even more, it is very, very difficult to do 24-hour dietary call. And therefore, these minimum dietary diversity scores are of great importance. The benefit of these MDD is they are strongly and positively correlated with micronutrient adequacy of the diet in cross-country analysis using data from several low-income countries. And therefore, they can be used as a proxy for this aspect of diet quality. They can be used to monitor and evaluate programs that seek to improve the diet quality of resource-constrained settings, and India falls in that category. It can be used to calculate and report the prevalence, making it simple and easy to understand tool, and therefore it can be very easy to for communication and for making advocacy material. You can actually identify zones of vitamin A deficient, iron deficient zones, calorie deficit zones, protein deficit zones, and then when you want to do an intervention program, you focus your program in these directions. So these are the strengths. They're simple. It is easy to tabulate and to interpret. And the results are so easy to communicate that either at household level or at population level, these can be used. But there is some weakness that the tool must be adopted to include culturally relevant examples of food in each of the 10 food groups. For example, in a community which does not make non-vegetarian foods or eggs, some other great replacements have to be planned. So these have to be a little individualized. And also, the enumerators must be properly trained to understand that you could tick mark a particular food group, only a 15-gram portion of that food is consumed. And you cannot be using seasonings and condiments as as a food group, because the quantity that is used is very, very important. Now, the weakness, as I said, that the strength is it is simple, and the weakness is it cannot replace a 24-hour dietary call method. It just gives a quantitative method, qualitative method, and not the quantitative method. So now the Indian government has also trying to bring out a lot of dietary norms. And one such very, very beautiful document by the government is the JSSK, the Janani Sishu Suraksha Karikram. The JSSK has also brought about the operation guidelines for the state program managers to be followed in the public health facilities. And in this, they have demonstrated so beautifully the RDA, which is as per the ICMR 2010, the total amount of energy, protein, fat, calcium, and iron intake for pregnant and lactating mothers. They have also categorized this further into the food groups. And they said that the food groups in the form of 3 main meals and an additional snack for pregnant mother and 2 additional snacks for lactating mothers have to be given. They have given the amounts of cereals or millets, pulses, which is 80 grams, green leafy vegetables, which is 50 grams per day, other vegetables as 300 grams per day, fruits as 200 grams per day, milk or milk-based products as 500 grams per day, fats and oils as 30 grams per day, and sugar and jaggery 20 grams per day. Now, we therefore, these are the pictorials of the same diet which is represented in the Janani JSSK booklet, that how adult women should portion out her thali, and the shape, the size of the thali is also mentioned, that this is a full meal and this is a snack in between. And for pregnant women, she should have 2 snacks in between the meals. And for lactating women, she should also have snacks after every meal. So minimum acceptable diets with adequate diversity is now also an internal part of the Indian system. And therefore my urge to all the field workers who are working in the area of MIYCN to use single indicators to report, and those indicators can then sum up to a very good data pool. So now I'm sharing some of the results that we have done this year. And we have seen that of around 750 mothers, the pregnant, newly delivered mothers that we have assessed, there is a very poor consumption of various important food groups like vitamin A foods is only 1.1%, dark green leafy vegetables is only 14.6%, Of course, egg, meat, fish, poultry, we understand that some of them are vegetarians, but then there is a poor consumption of even nuts and oil seeds, and the major part of their meal is only carbohydrates, which is coming from grains. So these are the another case studies results that we are trying to show, that in comparison of the diet intake between mothers who initiated breastfeeding within 1 hour, and after 16 minutes of 716 mothers that we studied, the minimum dietary diversity score for women was only 2.8, which is really, really pathetic. So this is the meal that is served to them in a hospital setting. And it is very important that somebody is a specialist, or efforts are made to take care of this meal which is served to the mothers in the hospital setup. And as I mentioned earlier, the diet is primarily rich in only grains. It is lacking in proteins. It lacks in vitamin A and iron-rich foods. So again, coming back to JSSK dietary norms, special consideration for high-risk pregnancy and anemia have been very beautifully defined in this book. And they also emphasize the use of fermented foods for good gut health and avoid tea and coffee. They emphasize the eating of folic-rich, iron-rich, vitamin C and B complex-rich foods. They also have, JSSK also have now guidelines for hypertension, for gestational diabetes mellitus. They talk about the control of the carbohydrate portions, about complex carbohydrates, avoidance of simple carbohydrates and sugar, and how to space their meals in order to maintain their blood sugar levels. Diet during the transition phase between pregnancy and lactation is also being very well defined in JSSK, and how normal portion of the same diet can be divided into various parts. Addition of iodized salt, which is available in all the government setup, needs to be consumed, and even hydration therapy is mentioned. Sample menu for vaginal delivery for a normal diet is also mentioned in the JSSK, and also a transition from a liquid diet to a normal balanced diet within 3 days. Advice is given in the JSSK manual, which is liquid for any clear soups or dal waters, to soft diet to a normal balanced diet after the lady passes her stool. So the dietary norms for mother at the health facilities with a functional hospital, a kitchen and a refrigerator, and with a C-section delivery, what can be done is also beautifully defined. It is a free document which can be downloaded and used and promoted in all the hospitals, and I urge everyone to look at it. So another very good example of dietary norms after a C-section delivery of soft meal options are also provided in this. We'd start with a glass of milk, upama, mid-morning snack, and then lunch, evening tea, and followed by a dinner. So in lactation, daily energy requirements are increased by 600 kilocalories in the first 6 months and 520 kilocalories after the 6 months is over. So you need to have additional meals of cereals, pulses, and you need to give them extra iron, calcium rich diet, which is good in proteins. And some of the important points for lactating mothers are you need to have enough water, which should be safe. It can be in the form of milk, soups, or butter, in buttermilk. And there are some galactologogues which are also like jeera, soft, ajwain, garlic, fennel seeds, nuts, corn, besan laddu, ginger, which are also advised. And for food, the water safety norms have to be followed at all stages. This is another work done by our team by Chitra and et al., where we have identified the availability of food safety nets in the lactating mothers, and we've seen that not everyone avail the facility of the packets, the supplementary food packets, which are given in the Anganwadi center. So there is a need to sensitize these mothers also, to empower them and improve their dietary diversity scores, and also improve their food and nutrition security. So the dietary diversity scores for lactating mothers when we evaluated this also as compared to the pregnant mother scores, we saw that there is a very poor dietary diversity score even in the lactating mothers. And only 45.6 mothers scored a positive dietary diversity score, which means that over 50% of the mothers are not eating healthy foods, which is again a cause of concern. So these are the references which I have used for all the scores that were calculated. And it is very, very important, therefore, to ensure that minimum acceptable diet is there for pregnant and lactating mother. Awareness is the key, and comprehensive data sets on diets and diet quality from nationally representative surveys are very limited, and that we all need to work in that direction to improve the diet quality. And I would sum up by saying that despite economic development, household access to sufficient and nutritious food still remains a challenge in poor rural households. Assessment of nutrition and food insecurity and education for minimum acceptable diet and minimum dietary diversity score for women is just therefore very necessary. In this COVID pandemic, we have seen that the food and nutrition security has deteriorated. There are so many aroused food insecurities. There are changes in the market access. There are changes in their income, food prices, and we all are evolving to learn new adaptation of coping mechanisms and mitigation strategies. So mitigation strategies should be now included in the curriculum of the food and nutrition courses in order to improve the food and nutrition security globally. And with that, I leave the floor to my next speaker. He's going to talk about very good examples of MIYCN and relactation. Over to you, Vandana ma'am and Vicheta. Thank you so much.
Thank you, ma'am, for the insightful presentation. We'll take the question answers towards the end of the session. I now request Professor Uma Iyer to introduce our next speaker.
Can I have the slide, please?
Bhaskar, are you sharing?
Our next speaker is Dr. Vandana Agarwal. Dr. Vandana Agarwal did her PhD from the Department of Foods and Nutrition and joined the department as a lecturer and has good academic experience. She had a lot of work in the area of community nutrition and therefore joined the as a nutrition specialist UNICEF in Bhopal. And after gaining lot of experience and looking at her experience at Bhopal, Vandana had worked at Angola, Zimbabwe, South Sudan and Afghanistan. Now we have a speaker here who has both academic and rich field experience both at the national and international level. And I think people are looking forward to your presentation, Dr. Vandana Agarwal, on effectiveness of supplementary suckling techniques for the infants with SAM and underweight infant. Welcome, Dr. Vandana. Over to you.
Thank you so much, Uma. Now, since I'm trying the share screen, yes, here is my presentation. It's always a pleasure to talk with in the department. And whenever I start my presentation, is the screen clear to all of you? Are you getting it? Or let me make it.
Yes, ma'am. Yes, ma'am.
Yes. Let me make it slideshow. Okay, just give me a few seconds. Okay. So first of all, thank you for the nutrition department, Uma, Vanisha, Meenakshi, everyone. I'm so glad that I'm again on this platform and sharing with you some of my experiences of Africa and in India. And basically during this important week, that is World Breastfeeding Week, where we are talking about the different issues related to MIYCN as well as the breastfeeding. Now, to start with this presentation, you can see in the first slide of this picture, which really highlighting that breastfeeding is not only an issue of a mother. Father is equally responsible, and which has shown by in Khalwa district of Khandwa, Madhya Pradesh, where a father who is around 38 years old, he is helping the mother for relactation of the baby. This child is being admitted and he was severe acutely malnourished, and they are trying the supplementary suckling technique. And since mother was trying to help the baby, baby was very small, father was holding the cup and making sure that baby should start the breastfeeding. So this is the way I'm starting, that how breastfeeding is the responsibility of all family members, not the mother. So let's talk about the effectiveness of supplementary suckling technique. Now in this presentation in 15 minutes, I know it's very difficult, but I will try my best to justice with this thing, because many of you are aware about the supplementary suckling technique, but many of you are not. So I will try my best to give understanding as well as talking about the effectiveness. So in this, we'll talk about what are the feeding guidelines, what are the supplementary suckling technique and its effectiveness, and how we can provide the support to mothers of below 6 months old who have been admitted in stabilization center for treatment of severe acute malnutrition. Now the question arises that why special attention for children less than 6 months? Usually what happens when the children born with the low birth weight, especially the infants, and they have the feeding problems. Now when they have the feeding problem, so they are already they have low birth weight around maybe 2 kg or 1.5 kg. They are too weak to suckle and they are too weak to cry. So thus they got neglected. You can see this in picture. This picture is from Uttar Pradesh, where we found in one hut, this mother has put the baby in the corner. And when we asked, do you have any child with the breastfeeding challenges or the severe acute malnutrition? She said, no, my child is healthy. But somehow, like, we have been trained in such a way to find out this type of children. And we reached to this baby. I said, who's this? Okay, he's perfectly fine. I said, why? Her answer was, this child doesn't cry. So the point which I'm making, the severe acute malnourished infants, they are too weak to cry. So they got thus neglected, and mother think that baby is fine. Now when they are neglected, and also when they are not suckling, they have no strength, they do not suck enough. When they do not suck enough, mother do not stimulate milk. When mother do not stimulate milk, less nourishment is less nourishment is passes to the infant, and then this leads to the more severe acute condition and sometimes a high mortality, and they are often infected with the many things. So now let's see that why this child in another situation, that if they are not underweight, why they get malnourished. Sometimes first was the scenario when the children born with the underweight. This is second scenario where the children, they got, like, they were fine, there's 2.7 kg or 3 kg. This is a clear picture of Luanda, Africa, where I found this baby in one of the stabilization center. This child, he was 5 months old, and I asked mother that what was the birth weight. Birth weight was perfectly fine, but due to inadequacy of milk, due to various reasons, mother was quite depressed due to the civil war situation, and she was so much stressed that she was unable to produce the milk and passing it to the baby. And also there are other reasons other than this mother, that recurrent infections, abandoned babies. So they are the different reasons for why children under 6 months get malnourished, even if they are born with the normal weight. So what are the criteria of admission and discharge to the infant who are less than 6 months in the stabilization center or health facility? Now let's see the admission criteria. If any mother, she has presented herself to the health facility with the problem of breastfeeding, or the infant is too weak to suckle, or mother has this feeling that she doesn't have enough milk. Another reason is there is a bilateral edema which we find on the infant less than 6 months. So these are the 3 criteria given by WHO, that in this case the child has to be admitted who is less than 6 months. And the criteria of his discharge is, we help them with the supplementary suckling technique. Once there is a restoration of breastfeeding, once the weight of the baby is increasing alone with the breast milk, not with the F100, which we start in the supplementary suckling technique, irrespective of his current weight or weight or height, as per the we do in the normal case of severe acute malnourished children. So how do we start? First, we start with the counseling, then correcting faulty positioning, ensuring proper attachment, and after that we see that everything is fine. Then we introduce the supplementary suckling technique, because the idea is not that the 3-month-old or 4-month-old baby, we just give them the top feed and then we make the weight is all right, you go. No, the idea is to make sure that relactation should be adjusted. The mother should start producing the milk and baby should start increasing the weight on breastfeeding alone, because when they enter in the stabilization center, they enter with this problem that mother is not producing the milk and we are top milk. So how do we address? So in this case, the mother with the lactation failure, we introduce the supplementary suckling technique. Now, supplementary suckling technique usually WHO has prescribed in emergency condition, but nowadays, like from last few years, it is also started in the special condition, because it's not only emergency, it's a technique which can be used as a strategy to initiate relactation in mothers who have developed lactation failure or mother's milk insufficiency, and which is very, very important. Now, what are the feeding guidelines? First, consult the mother and decide the feeding schedule. Now, why this first point is very important? Because the entire challenge of restoration of breastfeeding depends on mother. Imagine a mother who has to feed 16 times in a day. Because if we put the baby on 8 F100 feed, so 8 plus 8, 8 times she has to breastfeed, because it's alternate. First we give the breastfeeding, and then we give the this supplementary suckling technique F100. So we decide, sometimes the mothers get adamant that no, I cannot feed 16 times. Sometimes they said, let's discuss 14 feeds, 12 feeds. So this time the negotiation of the nursing staff and the feeding counselor with the mother continues. And once we decide the feeding schedule, we start the F100 diluted, and we usually it is advisable there should be a breastfeeding corner in the place where we start the supplementary suckling technique. Either it should be in stabilization center or an NAAC or malnutrition treatment center or any health facility. Even nowadays, like in few area in I think in some districts of Madhya Pradesh, the Anganwadi worker, she started at home because mother was not ready to go to stabilization center. So we can do it at home also, but in the supervised condition. Now, how SST works? You can see here that a baby is on the breast, and on this breast there is a one tube is being attached, which is attached with the adhesive tape. Someone is holding the cup with the F100 diluted. So basically what we are doing, we are using a breastfeeding supplementer. So this tube, you can see that this tube is breastfeeding supplementer, and which leads from cup of supplement to the breast and which goes along the nipple into the infant's mouth. Now baby thinks that he is drinking milk from mother's breast, but ideally he is not. He is just sucking nipple. He is continuously sucking nipple, but since the tube is being attached to the nipple, he suckles and stimulates the breast at the time. Also he is drawing the supplement, is expressed through the tube, and it's thereby nourished and satisfied. So in a way, baby is getting the satisfaction of breastfeeding, but he's getting the nourishment through this tube. And third is, during this suckling process, the let-down reflex also stimulated, and stimulation helps in production of the breast milk. So what is the exact technique? We have to take a tube, which is nasogastric tube number 8. Then you have to prepare the F100 diluted, put it in a beaker, and mother holds it, or sometimes the father help or any care provider. If mother is too weak, then one end of the tube is put in a cup. Another end of the tube is it is being stick with the nipple, and the infant is offered the breast. Mother holds a tube and uses the other hand for holding the cup, because it's 16 times, 16 or sometimes 18 times or 20 times we put as per the schedule. So she is usually holding the cup and helping the baby with the one hand so that the baby can breastfeed. And it may take 1 or 2 days for the infant to get use of the tube, but it is very important to continue. And in the first process, when we start, the first few hours or the half day is also irritating for mother as well as for baby. But slowly, both of them, they get used to, and this process started. Now, when the infant sucks on the breast with the tube is in mouth, the milk from the cup is sucked up through the tube and is taken by the infant. The cup is placed at least 10 centimeter below. This is very important. Many times the nursing staff, they come and complain, ma'am, you are asking us to do the supplementary suckling technique, but this is not working. And when you go and observe, you find that they have taken the cup, which is up or from the breast. No, the level should be down, so that the suction process should go, and there should not be any distress to the infant. And when he sucks, when he or she sucks, the milk goes easily to baby's mouth. The phase 1 is, first is breastfeed every 3 hours, duration at least 20 minutes, more often if the child asks for more. After breastfeeding, complete the second feed start with the F100 diluted using supplementary suckling technique. I repeat because this is sometimes very complicated. Those who understand, no issue, but those who are listening this presentation first time, I'm explaining it again. First feeding, breastfeeding alone, whether milk coming or not coming. So whatever there is a little bit of milk in mother's breast, baby gets it. We finish this after 20 minutes, for 20 minutes duration, then give a break of at least 20 or 30 minutes so that mother gets some rest. And then again start the breastfeeding along with the supplementary suckling technique and F100, which is put it in a cup. Now this is the schedule. Now you can see this is the 8 feed. So 8 multiplied by 216. So in that case, and these feeds and the quantity of F100, it has been decided by the weight of the child. If the weight of the child is in between 1.8 to 2.1 kg, we will give 40 ml of the feed per day, per feed, so that in each feed baby gets, you can multiply that 8 feed multiply by 40, so it's around 320. So this way, an F100 we never use undiluted, because usually when you treat the severe acute malnourished children, you treat them with the F100 normal. But when you prepare F100, it is diluted, and dilution procedure is again different. Those who are interested in more detail, I would be happy to share a more detailed presentation and the guidelines which I have. You can just email me, or you can ask Vanisha and Professor Uma. So I would be happy to share. Now the another case is the children, those who have the edema. We cannot give them F100 because F100 has sodium. So to reduce, and we do not want to give any feed with the sodium to aggravate the situation of edema. So in that case, F75 is given to the edematous infant. Now what is the effectiveness? This data will show you. We tried in Bhopal, Indore, Khandwa. This is the data of all region of Madhya Pradesh, where around 1,000 children, they have been tried with this supplementary suckling technique in 2008. You will be surprised to know that, like first case in Bhopal and Hoshangabad division, when the total children admitted in NRC, they were 258, and the number of children who have been introduced to SST, 62 children who were less than 6 months. Because rest of the children handled with the only counseling, proper positioning, and the breast milk initiated, so we didn't have the SST. Now, the 62 children, out of 62 children, 47 children, they achieved successful lactation through SST. It was a big, big, big achievement. And imagine, first case, 11 children in just within 3 days. Then 19 children between 4 to 6 days. And the children, those who were very weak, they took 7 to 9 days. So this was so successful. And that's why we, in all 340 nutrition rehabilitation centers of Madhya Pradesh, we pushed a lot with the help of gynecologists, with the help of pediatrician, with the help of nutritionist, dietitian, that please initiate the SST. Please make sure that mother should start and mother relactating so that we can help the baby. This is another case of Bhopal and Hoshangabad division. And this was done by Resha, one of our nutrition students. She worked very hard and shared this data, that how in less than 3 days, the 44 children, and in 4 to 6 children, 126 children, they got the successful lactation. So this is the effectiveness. And if you like, just while today morning, I was just going through the internet and trying to see few research studies. surprisingly, like I was thinking like at least I will get 20-40 studies, but there were only few studies, one study from Maharashtra and another 1 or 2 studies. So I would request if nutrition department can take a lead and do the research on this and really push supplementary suckling technique in entire Gujarat region, and also the research will help in the India also other people to understand that this is very, very effective. Because not only in India, we tried in Africa, in all other countries, in the emergency situation in South Sudan, in Luanda, in Ethiopia, and in Ghana, where but since they do not have the very good health infrastructure, I will not say that it was successful 100%, but at least 30 to 40% of the centers, they were starting the SST, which was very, very useful. But along with the supplementary suckling technique, as per the WHO criteria, infants less than 6 months, they also need some treatment protocol as per the normal treatment protocol for the children for the severe acute malnutrition. These are the dose for vitamin A, folic acid, ferrous sulfate, and antibiotics. And along with this, the support is provided to mother also. But for the time, since the time period was quite short and I have to cover in 15 minutes, I removed more than 20 slides, which is explaining the how it is helping the mother and what is exactly the detailed procedure and some videos. So maybe next time whenever I visit department, we can take this in detail, because this subject is very close to my heart, because in this case, we are helping the mother for relactation, and once she admitted for 10 to 15 days, she can feed the baby up to age of 1 year. So the surveillance is, here is one case from Africa, another case is from India, Madhya Pradesh. Here the nursing staff that, she is Asha. Yes, this Asha worker is helping the mother. And again, this is the Shivpuri district mother, and this baby was quite undernourished. So how do we do the surveillance? Weigh the infant daily and see if his weight is increasing. You start the supplementary suckling technique, you're giving breastfeeding, and you're taking the weight every day. But the scale should have at least 10 to 20 gram precision, because the weight is increasing 50 grams or maybe 40 grams. So the scale should be very, very good. And if the infant is taking the same quantity of F100 diluted and weight is increasing, it means that breast milk quantity is increasing, because day one, when you start and the baby's weight is 2.2 kg, and then again second day is 2.210 or 2.250, it means even the 40 grams or 50 gram weight is increasing. It's not from F100, because F100 will not allow it sustain the weight, but it will not allow weight gain. So if weight is increasing of baby, this is clear-cut indication that due to this supplementary suckling technique, the milk production has started, and mother has started the producing milk because of the suckling, and that's why the baby's weight is increasing. So what do we do? So when the infant is gaining weight at 20 gram per day, whatever his or her weight, decrease the quantity of F100 dilutate to 1/2 of the maintenance intake. And if the weight gain is maintained 10 gram per day, then stop supplementary suckling technique completely. And then put the baby again in center for 1 more day for observation. And then sometimes we keep it 1 day, sometimes for further 5 days on breast milk alone, to make sure that he continues to breathe. If next 5 days with only breast milk, weight is increasing despite the weight for height criteria, despite the criteria for the admission for the SAM children, the mother should be discharged so that she can continue breastfeeding at home. And this way, this is clear-cut indicator that this is a success of supplementary suckling technique, and relax started. So now mother can go home easily. Thank you so much.
Thank you, ma'am, for the wonderful presentation, and especially for bringing up the issue of the neglected children less than 6 months of age. I would now request Professor Uma Iyer, ma'am, to summarize the session.
Both the presentation was excellent, and it was highly focused, and is that both aspects such that it can be implemented throughout India, and we can generate database. Now coming to Professor Vanisha Nambiar's talk on minimum acceptable diet, I think dietary diversity is being given lot of importance nowadays in for different age groups, especially the vulnerable age group, and it is a good tool to assess, or it gives an indication of the nutritional status, or we know the limitations of the food groups, because most of the times the neglected target group consumes only one or two food groups, which has been documented by the various people, including in Professor Vanisha's presentation, clearly shown that rich food groups are the neglected or the compromised ones. The other target group was for the women, and I think it is equally important because the mother-child pair, if we look into which we need to target, and therefore the tool now has to be scaled up, and there will be some modifications as suggested, because there are regional specific food and therefore alternatives may be worked out. But what is coming out is that can be implemented and put to use throughout India. A good database can be generated, implementing many of the programs that we want to conduct. The second speaker, Dr. Vandana Agarwal, talked of the supplementary suckling techniques, very focused and supported by several case studies. Now, the success story that has been put across, the data in Madhya Pradesh, I think if it can be implemented at India, and I think a lot of advocacy needs to be done for the supplementary suckling techniques, because it will help to reduce the prevalence of wasting as well as stunting later on till 3 years of age, if the nutritional status is improved right from the beginning. And research, even Dr. Vanna pointed out that very limited research is available in this particular area. So I feel that it needs to be, this particular technique needs to be propagated. And secondly, research needs to be as well as the child. I think both the presentations were excellent. Both can be scaled up at the national level to evolve a good database, and looking forward to future research in this area in the department and elsewhere in the country. Thank you so much.
Thank you, ma'am, for summarizing this session. There is a question for Professor Nambiar. Many of the studies in India have shown that more than half of the pregnant women have eat less than. How can we achieve adequate diversity for them? What could be the strategy?
Yes, so there are several studies, even our own studies have shown not even 4. 2.8 is the figure that we got for dietary diversity score. It is a pity. Acceptability of food is a problem, affordability of food is a problem, and awareness is also another big problem. So education and counseling is the need of the hour. And as I said in my last slide, Now we have to design curriculum for mitigation. We have to define curriculum that what we can do when we are in poorly resourced communities or settings. What are the various positive deviant factors or behaviors that we can bring out? So as our Prime Minister is saying, go vocal for local. Find out each of the dietitians or each of the nutritionists are there. Even Rajasthan had its own hair sangri and dal bati churma and other. So micro and iron may not be what is written in the textbooks. There are many things which are still available in the particular area which needs to be promoted. Second food group is cereals. The third food group is oil. And fourth food group is little milk in the form of tea. This is what is our study showing. So it is really sad. People have to be educated. That is not to educate the masses for that. It's the Eat Right movement which has to be initiated. Yeah, thanks.
Thank you, ma'am. Vanda ma'am, there is a question for you. Swatis has asked, any case of contamination of tube you've come across or episodes of diarrhea due to that?
Okay, so basically when we use this nasogastric tube number 8, we open it from the pack and we insert it. Now I should be used. We had the problem of this buying it every day. So what we used to do, we have asked nursing staff, this sterilization process was 2 times in a day. It will not cause any diarrhea. The cases of diarrhea was not reported. There was another one question which I saw in that case. They asked that how about the lactose intolerance? So, this F100, if you see the composition, it's not. It doesn't have the milk powder, so it's free from that lactose thing. So it's not because it's especially designed for the children with the severe acute malnutrition. So that's not an issue. Children with the lactose intolerance can easily take F100 diluted.
Request the panelists if they want to pose any question.
Sheila ma'am and Archana ma'am, can you switch on the videos? We can have a good discussion. Both of them are together. Sheila ma'am? Archana ma'am? Same question to you. How easy is it, or will it be feasible for us to study relactation techniques in Department of Pediatrics?
It can be studied. Only thing is what is required is others do come to our OPD or follow-up clinics. So, I mean, what happens is in the routine busy OPD, they're told to continue. Instead of that, probably such mothers, we could admit them for 1 or 2 days if they are ready, then work with them for at least few days, because it's not on a single session that they would get convinced, as well as it will give result. It really requires some patience. So probably it can be done in the few cases if they agree to stay. And then we have some one-to-one person working with them.
So that is,
or at least, yeah. So even in OPD basis, we have kept one nutrition counseling room where lactation counseling also can be done. Probably if she's not ready to stay, we can, because when Neha was there with us, before she left, we had started it. So we could restart it. My problem comes in OPD is a dedicated manpower for that. So it can be done. Because it requires a lot of conviction both ways, for the mother as well as for the counselor.
Ma'am, would you like to?
Yes. because I would like to share my experience both of India and Africa. As Professor Sheila rightly said, it's not only the mother. Mother is always ready to, because she is very keen to for the relactation to start. It's very difficult for anyone to prepare the bottle and give it to baby, and they just want baby to be healthy. So basically, it's a committed health staff at the health facility, whether it's your feeding counselor. I don't know about the structure of Gujarat because I'm not in touch, but I know in Madhya Pradesh under the National Rural Health Mission, there are around 300, 400 nutrition rehabilitation center. And in each center, there are 3 posts. One is feeding counselor, one other is the, I forgot the title. There are 2 more people to support. So these are the 3 staff, and they have the duty of 24 hours, like they work in shift. So in that case, when this type of mothers, they admitted along with their kids in the nutrition rehabilitation center, they work with them, and continuously every 3 hours, you have to go, you have to remind the mother, now it's a time for breastfeeding. Now after 1 hour, now it's time from supplementary suckling technique. You have to stick the tube. You have to make sure the tube is sterilized. You have to make the F100 diluted freshly. So it requires lots of commitment. And if they are dedicated, the health staff is there, it can be done. Like picked up and they found it so easy. They said, how come it is possible? Like it was very difficult for them to accept that a mother with the dry breast, and she said, I do not have a single drop of milk. How will you help me? And after 3 days, she's smiling because milk is just coming out and like anything. So this is really, it can be done, but require lots of commitment from both the side. Mother should be ready to sit for so many hours.
Person or counselor who is working, they should have seen at least one success story. Then their confidence also gets boosted up.
Right.
Because that negativism in themselves sometimes creates the barrier.
But I think lots of research is required. We need to explore, and we need to, if we do some success story in Vadodara itself, like it will set up the example for the other districts of Gujarat, because in Gujarat the severe acute malnutrition is very high, and if you see in the children less than 6 months, there are quite a significant number of children out there. They really need help, and nothing can help. Neither we can give them RUTF, nor we can give them F100 or F75. They just need breast milk. So how do we start the breast milk?
Again, these are the children who've been VLBWs or those severe IUGRs who falter into SAM in the first 6 months itself.
Right.
And the problem does come that when the weight gain has not been occurring, they introduce early top milk. So everything becomes a vicious. So one thing of that, when you have a VLBW or a small baby, less than 1.8 kg, the first 4 weeks, your establishment of breastfeeding and the confidence that the mother gets, probably that will make sustainable breastfeeding in this high risk group. Because these are the ones who are coming back at 4 months, 5 months as SAM,
right?
Especially from periphery.
Manisha, you can take the initiative in your department if some of the teachers they are interested and the students they are interested, and you can collaborate with the pediatric department and gynec department of Vadodara. You can start this, and if you any advice is needed, I will always there to support you.
Thank you. I was coming to that only because already we are working with Sheila ma'am, and OBGY is since I think 3-4 years now, and institutionalized deliveries, follow up, and making Baroda baby friendly is my dream. And if relactation technique can also be introduced in that, and we can train the NRC girls. So I think we will move towards that direction. Thank you so much. And I know you're
good.
Isha,
would like to request
Meenakshi for your lactation management workshop. You should use this technique for your lactation management workshop when you do, no, on MIYCN, etc.
Yes, yes.
Include that.
Yes.
And slowly we train our own students on this so that we can work on this strategy. And
very good suggestion, Meenakshi.
Thank you so much. It's always very, very, I feel very proud of you, and the time is always less to listen to you. So we should have at least, maybe 1 or 2 days to listen to your experiences. It's a great to listen to you, and thank you, Vanisha, also. It was a very good presentation.
Dr. Sheila, I just want to ask you, since your OPD is always full, okay, so can you have a monitor over there where this kind of of information like say JSSK menus and about dietary diversity, what nutrition they should have, related to diets. Then early initiation of breastfeeding. Those can be a continuous shown on the screen. At turn comes, it will be observing that, and sensitization can start.
We have in our about breastfeeding, the postnatal ward, and all this where the poor mother's care, it's there. In NRC we have put up, and even in OPD there are 2 screens, so which can be increased. My NRC nutrition sitting in OPD, and every child at least gets carrot and SAM, and accordingly now we started OPD follow those who are not ready for admission. That we found means from the period of lockdown, my OPD attendance is really markedly decreased. They come only if they require. Are they worried about immunization is also really gone down. So we have back to start working from that for our normal things, they start coming back again. That's a very important healthcare intervention which should be to all levels.
Thank you to all the speakers, the panelists, and our chairperson, Professor Umayyar ma'am, for conducting the session today. So